thank you again for bringing back to New York, and thank you for who stay in the room late. So I will try to explain how to perfect the treatment of segmental saphenous reflux. I have shown you last year a typical clinical case by Zoom at that time of a C2 young lady, very active but with significant symptoms. The ultrasound assessment showed a segmental GSV reflux from mid-thigh to the knee with a competent trunk above a refluxing thigh perforator and below the emergence of varicosities at the type. The treatment was performed by the microphlebectomy technique under tumescent anesthesia in a very mini-invasive way. The results and the control at 18 months showed excellent results, no residual varicose vein, no symptoms, perfect cosmetic results, and the competence of the GSV and the thigh perforator. So even if we have been very happy with this case, should all segmental GSV reflux be treated like that? Since the segmental saphenous reflux have been clearly identified in this classification of saphenous reflux that we have published many years ago, and because we have integrated this classification of reflux in our database, and because they are filled for all patients with varicose veins, as it was the case for this lady, we wanted to study the management of varicose vein in our daily practice in this situation, in this case of reflux. So we have reviewed all patients treated for varicose vein with GSV reflux during 4 years, focusing on patients with varicose veins and segmental GSV reflux identified as 3A. 460 limbs have been operated. The characteristics of the patient were not specific, predominantly female in their early 50s with the average French BMI. But the proportion of C2 was very high, close to 84%, and symptomatic in only 60% of the cases. The treatment consisted in microphlebectomy with sparing, saphenous sparing in 98.7% and a saphenous ablation in only 1.3%. The comparison of both cohorts treated by ASVAL and laser surprisingly showed only two significant differences, which was that all the patients treated by laser were symptomatic and all of them had a predominant epiphyseal GSV course at thigh. The midterm results showed complete abolition of the saphenous of the GSV reflux in 88%, a symptom release and a cosmetic improvement in 97-98%, presence of varicose vein in only 4%, and no need of any kind of additional procedure during the follow-up. So, looking at the result, we can say that in our daily practice, segmental reflux of GSV led to microphlebectomy alone. In almost all cases, only a tiny percentage of segmental reflux have been treated by laser. It concerned the most symptomatic patients with a predominant epiphyseal GSV course at thigh. This situation occurs when the saphenous, the GSV becomes epiphyseal at mid-thigh, where we have treated the proximal intrafascial segment by endovenous ablation and the distal epiphyseal segment by phlebectomy, in order to avoid the risk of thrombosis of the remaining short proximal intrafascial segment of the GSV. So we have got excellent results by this strategy from a hemodynamic point of view with a very limited risk of thrombosis and with excellent clinical outcomes with no need of secondary major procedure. So looking at that, we can assert that microphlebectomy and preservation of the GSV should be the treatment of choice for a segmental GSV reflux. In conclusion, the saphenous sparing strategy is the quasi-exclusive mean for treating a segmental GSV reflux in presence of varicose vein in our practice. The saphenous ablation, in our opinion, should only be used when the GSV segment at the thigh is predominantly epiphyseal. And at last, a segmental GSV reflux is probably one of the best indications of saphenous sparing approach, according to our large experience for many years. Thank you.